S2. What could cause S2 compression? What congenital anomaly? It's super simple. They're making this way more complicated than it needs to be. Okay, there's no disc there, right? Except for when there's a disc or a pseudodisc. Okay. All right. You guys ever heard of lumberization? Lumberization? I guess not. Okay. So lumberization means that the sacral area has taken on characteristics of the lumbar spine. It's called a transitional vertebra. It exists in up to about 25% of people have some level of transitional vertebra. You could have a hemi-transitional vertebra. You could also have what's called sacralization of the lumbar spine. This is fairly common. So in a sacralization of the lumbar spine, essentially what's going to happen is you're not going to have a disc between L5 and S1. It will be fused. It can also happen on half of the side. So you won't have a foramen on one side. In somebody with lumberization of the sacrum, essentially what happens is they have an L6 vertebra. As a result of that, there's going to be excessive movement between L6 and L5, or S1, okay, and S2. Generally speaking, you may have a pseudodisc, you may not have any disc at all. What you're going to get is movement there, but without any cushion, which can lead to grinding. With that extra movement, it is possible to have impingement of what nerve root? S2. Okay. Also, another characteristic that could somewhat lead to this could be something called spina bifida. Spina bifida occulta, of course, being the more prominent one. It's much less as far as symptomatology. They usually have a little hair tuft there, and you can see it on imaging. We'll see it in our radiology class. There's literally a hole in the spinous. The spinous didn't close itself during the neurodevelopmental process, and they will have a little bit of a nerve at their spinal cord will come out the other side. So those patients, you have to be very careful that you don't press in that area because their nerves are not protected by the posterior elements of the spinal cord, which is the job of the posterior elements, correct? So transitional segments can certainly lead to lower back pain, grinding. That's one of the issues that Alicia at our office has. She has a hemivertebra at L5, L6, so she has a transitional extra segment there. And what happens when she moves is it slips and grinds and it creates osteoarthritis in that area. So she is more likely to have an S2 radiculopathy. Okay. So how does her dance go again? C5, C6, C7, C8. Hey! Okay. So that's how you're going to use that, right? So upper body is actually fairly easy. You have the dance, right? You have C5, C6, C7, C8. Okay? And then when we talk about the lower body, L5 is going to be what dermatome? Big great toe. Just the big toe. Crossing over. You were right before when you were talking about great toe extension. L4. Okay, sensation, great toe, L4. The other toes on the top are going to be L5. L4 is going to cross, okay, it's going to cross the shin. L5 is going to be more on the lateral portion of the calf, but going to the great toes, with the exception of the pinky toe on the underside of the foot. S1 is going to be the underside of the foot, traveling all the way up the posterior elements, the lateral part of the gastroc, the lateral hamstring, all the way across the piriformis to the sacrum. Okay, so I've got numbness in the lateral toes, and I've got weakness in great toe extension. What am I dealing with? Radiculopathy, what level? L5. Good. Okay, numbness traveling down the back of the leg, weakness in plantar flexion. What are my two options? Sciatica and S1 radiculopathy. Good. They can kind of overlap, and they can be confusing for people. Okay, I've got weakness in my index finger, my middle finger, and my thumb. Numbness in my index finger, my middle finger, and my thumb. Weakness in wrist flexion. What am I dealing with? Radiculopathy or neuropathy? Neuropathy, probably median nerve, correct? Okay, I've got weakness in wrist flexion and ulnar deviation, and I've got numbness in these two fingers. Radiculopathy or neuropathy? Neuropathy, what nerve? Ulnar nerve, good. Okay, I've got numbness in the pinky finger and the ring finger, and weakness in thumb extension. Radiculopathy or neuropathy? Radiculopathy, what level? C8, very good. Here we go. You guys are getting it. Repetitions, right? Reps, 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 reps. Okay, numbness in my middle finger, weakness in wrist flexion. What do I have? Radiculopathy or neuropathy? Where's flexion weakness?
So,
Neuropathy, what nerve? Median nerve, good. What are my median nerve entrapment sites? Peroneal teres and carpal tunnel. Okay. What are my ulnar nerve entrapment sites? Not carpal tunnel. Tunnel of Guyot and cubital tunnel. So underneath the piriformis, and then at the elbow. Guyot. All right, whole hand is numb. Whole hand is weak. Neuropathy, plexopathy, radiculopathy. Plexopathy, very good. Okay. Numbness and weakness only when the shoulder is forward in wrist extension. Only when the shoulder is forward. Plexopathy, neuropathy, radiculopathy. Plexopathy. It's the positional issue. Okay. So, by the way, the neck can involve and trick you as well. So, say I tilt my head to the left here, and it increases the symptoms in my right side over here. More likely to be neuropathy or plexopathy? Plexopathy. Okay, I'm actually opening the foramen more on this side, right? So there should be more space for the nerves. But what I'm doing is I'm increasing the tensile tension on the scalenes, which can draw the first rib up and give us symptomatology. So the first rib is now compressing the plexus itself and shooting down the arm. On the right side, it elevates. Right, so the scalene's attached from the vertebra to the ribs themselves. So the posterior scalene attaches on which rib? Attaches on which rib? Focus, guys. Second rib. Okay, anterior middle scalene attached on which rib? First rib. They both attach on the first rib. So if I tilt my head to the left, what it's going to do, it's going to cause tensile pressure on my anterior, middle, and posterior scalenes, elevating the first and the second rib. Particularly if the ribs are loose, which is very possible, okay? So say I have weakness and atrophy of my shoulder. I'm starting to develop shoulder pain. I've got some paresthesia here on the outside. What's my most likely? C5 radiculopathy. What could cause a C5 radiculopathy? Disc herniation, bone spur, spondylolisthesis. Okay, some sort of trauma around the foramen. Could be a space-occupying lesion, right? So if I have what's called a Pancoast tumor, have you guys ever heard of that one? So it's an apical tumor of the lung. It's going to move upward, and it's causing symptomatology in my hands. Am I dealing with a neuropathy, a plexopathy, or a radiculopathy? Pancoast tumor, moving vertically out of the lung field. It's going to be a plexopathy, right? Okay. Patient has a hand drop. They were stabbed in the shoulder with a knife. Plexopathy, neuropathy, radiculopathy. They were stabbed in the trap. Plexopathy. Remember, our nerves don't exist here yet. So when we're breaking down what these turn into, you guys remember the branches and the trunks as well? Okay. So those are a part of what structure? The brachial plexus. Okay. From the plexus, all those intertwining nerves are going to form our actual nerves once they come out the other side. At the quadrangular interval, at the quadrangular angle, all these places around the shoulder girdle where these nerves dance out and they give us the control of our fingers and our arms and all these other areas. Okay. Also, check this out. What you can have is a combination of them. So sometimes, and I don't want you guys, store this away for now. Don't think about this yet. But what you can have sometimes is radiculitis. So some inflammation of the nerve root that causes a little bit of swelling. And then when it gets to a certain muscle group, now I have a full compression, which gives me a true neuropathy downstream. That can happen too. For the purposes of your mind traps like I'm explaining to you now, don't think about that yet. That's when you've been a clinician for a long period of time, but it does exist. For now, you're setting up your discussions with your patients in the hopes of correlating these types of formulaic answers to we can figure out exactly where the level of lesion is. And we do have some tricks in our body, like I was telling Anthony a second ago. Some of the pathways in our spinal cord that give us sensation. So when we have sensations out here, right, we have our C fibers, we have our myelinated fibers. They're going to travel back to the dorsal ganglia. They go into the rex lamina of the spinal cord. They move up through certain pathways, particularly the spinothalamic pathways. Then they do what's called decussating. Okay, they cross over to the other side of the spinal cord. That gives us protection. So if our spinal cord gets cut at some point, we're still able to carry some of those fibers up to the top through your thalamus and to your postcentral gyrus, where your brain perceives what's going on in the world in your parietal lobe. Then it takes that information, it travels to the premotor cortex and the motor cortex, and then you move and respond to that. That goes through the anterolateral pathway. So these pathways decussate is dry out from my entomology days. They decussate at different levels in the spinal cord, and that's why it's important to memorize, so much of this anatomy. And again, we talked about the differentiation between neurons and nerves, nerve roots. They all sound similar, but they're dramatically different in how we use them to describe our world. Same thing when we were talking about before, when we were talking about spondylitic, spondylolisthesis, spondylosis, spondylitis. Okay, does everybody remember the five different types of spondylolisthesis? Dysplastic, isthmic, degenerative, traumatic, and pathological. 5 types of spondylolisthesis. Okay, a spondylolytic spondylolisthesis is which type of spondylolisthesis? The most common. Isthmic. Okay. A pathological spondylolisthesis comes about from what? Tumor, cancer, metastasis. Okay. Dysplastic means what? It doesn't develop properly, right? We don't actually develop the pars interarticularis. So just like dysplasia of the hip, dysplastic spondylolisthesis means we didn't develop the posterior arch of our spinal vertebral unit. Okay. Traumatic is what? A trauma. Right, you fall, you break it. Okay, and then our degenerative, so old people, right? They just wear them out and they basically disintegrate, and then we don't have the pars anymore, and so that allows one vertebrate to move forward relative to the other one. Retrolisthesis means what? Posterior movement of one vertebrae relative to another one. So if my L5 or my L4 is posterior relative to L3 and L5, we would call that a retrolisthesis of L4. It does happen occasionally. It's not very likely to happen there in the L spine or the C spine, again, because they're lordotic, so you're more likely to have one move forward. You are more likely to have, if you were going to have some sort of sthesis in the T spine because of the kyphosis, you would have a retrolisthesis. Okay, but the difference there is we have our ribs, so it's much harder to move one vertebra posterior or anterior because of the rib components that attach to the sternum. You have this secondary structural component that helps hold the vertebra in place. And then like we talked about previously, right, so the reason why you're less likely to have a dermatomal presentation in the T-spine is because of the kyphosis, when we have a disc herniation, the disc material is more likely to move anteriorly instead of posteriorly, which means it doesn't impinge upon the foramen. Okay, and the C-spine and the L-spine, the lordosis causes posterior movement. That's where your nerves are, and that's where we get impingement. The exception would be what disease? Or diseases? Shingles. Okay. Where does the chickenpox virus hang out? In your spine, right? Yeah. So then when your immune system becomes compromised, somebody that had chickenpox or didn't have chickenpox, I suppose, right? Isn't it? I can't remember which one it is. It's if you had it, right? Yeah, that's right. So if you haven't had chickenpox, you're more likely to have a much more worse version of chickenpox as an adult. But when you've had chickenpox, you're more likely to have shingles, which follows a dermatome, and it's super painful, and it usually happens in the elderly. Nope. Or the immunocompromised. So what are some ways you can be immunocompromised? No? Interesting. What are some ways that you can become immunocompromised? Malnutrition, but more specifically? Sleep deprived is one. Medication induced, right? So prednisone or chemotherapy or biologics can cause you to become immunocompromised, right? So those are all the rage right now because we have so many autoimmune diseases. So one of the big ones I always ask about is tuberculosis, right? Because if your immune system becomes compromised, you could be subjected to tuberculosis, which doesn't really exist anymore, but you can get it. So Humira and some of these other medications can cause that. They can suppress your immune system to the point where it doesn't function properly. So the problem is autoimmune cells, your B cells in particular, are attacking your own cells, right? You develop an allergic response. And you guys remember the difference between T cells and B cells? Which ones are more long-term memory associated? B.
Oh, because they make the antibodies.
Right. They build up the antibodies and they're more long-term. T cell are going to be your phagocytosis and macrophages and things like that. Which are, yeah. But your B cells are more long-term mediated. So the B cells are more involved with autoimmune diseases as opposed to T cells. So they start to recognize your own cells, whether it's your neurons in your brain or your arteries or whatever else is the enemy, and we start to attack it, punch holes in it, and that's what happens with Crohn's and ulcerative colitis and things like that, which are then treated with biologics, which suppress your immune system, which allow you to develop other issues like lymphoma or tuberculosis, or so it can't really win, right? So if I have a radiculopathy, okay, what are the odds that I also have a neuropathy? Is it high or low? Day to day, what's the odds of having either? Not super high, right? Okay. So the odds of having both at the same time are low, but not impossible. Okay. So if I had if I got kicked in the back of the leg, all right, I lost sensation traveling down the outer part of my foot, but the worst of it was over the big toe and the second toe. Am I thinking radiculopathy or neuropathy? Neuropathy. Right. Simple, right? So what nerve? The worst of it's between the great toe and the second toe. Nerve. Deep peroneal. And it will cover the same area that L4 will. But it's not L4 because I don't have a problem at L4. Right? So I jumped off a shed. Okay. Didn't have back pain, but now I've got weakness in knee extension and I've got numbness over the great toe. What am I thinking? Knee extension and numbness over the great toe, big toe. L4. Okay. L4 disc herniation would be my most likely. Okay. You don't have to have back pain to have a radiculopathy. Many medical professionals will assume that you will, but most cases that I find that there's actually a significant radiculopathy, there was pain originally, but the pain in the back actually subsided. So they don't actually have back pain oftentimes anymore. They have leg pain and numbness. But because there's not back pain, many medical physicians will decide that it's not coming from the back, and they'll look downstream. In fact, one of the spine surgeons that I saw recently that I told you guys wasn't having any back pain, but he was having weakness in the arch. He was having some numbness there, and he just assumed that he was having entrapment at the foot or at the knee or some other place. Okay, but it's coming from his spine. But because he didn't have back pain, people assumed that it wasn't coming from the back. Now, if you also have back pain, does that make it more likely? Well, yeah, a little bit more likely, but it's not a necessity for a lumbar radiculopathy. Same thing with neck pain. Okay, and there are some sclerotogenous referrals too, so if things weren't complicated enough, we can talk about sclerotome referral. Okay, so that's going to give us referrals from connective tissue structures and joints and other types of structures as well. So some common ones you'll find, and that's not even counting trigger point referrals, right? So think about all the different types of referral patterns here. So one of the most common discal, so from the actual disc material in the facet joints itself for C6 is going to be into the rhomboid. It's not nerve, but it's giving you a referral from the structure because, again, we don't necessarily have the neural capability to tell us where there's something wrong. So this isn't compressing a nerve, it's actually telling us where the problem is. Just like if you have a problem here, you'll fill it up into your head or your eye. Right? If I have a C1, 2, or 3, radiation, it can travel up along the trigeminal nerve, particularly the V1, the ophthalmic branch, but also the maxillary and sometimes the mandibular if it's a lot of it. And the reason why, of course, is the trigeminal nucleus gets hijacked. It shares the same neuronal pathways. Okay, so what can happen there is the disc itself or the bone itself will refer pain because it doesn't necessarily have a lot of pain structures. And that's the thing that people don't really realize. Why would you need a lot of pain structures in your spine? Generally speaking, if something's damaged your spine, you're not going to do very well. You're probably going to be dead. You're going to be paralyzed and therefore roadkill or eaten. Just like your brain, just like your internal organs, they don't have a lot of pain receptors. Biologically speaking, they shouldn't, right? The homunculus is what we talked about before. Most of our pain receptors are where? In our fingertips and our lips and our toes and our genitalia. That's where we're going to have the most brain interpretation of where pain is. We don't have any in our brain. We shouldn't, right? Biologically speaking. You're not going to have a whole lot actually in your spine itself. And that's the mess up in medicine. Because we can see discs very pretty on MRIs, we've come to the conclusion that discs are the cause of all pain. And in fact, radiology reports are based upon the clinical treatments. So when you're reading a radiology report, they're going to give you what they believe is wrong based on the clinical procedures available at the time. They're not going to report multifidi atrophy bilaterally. They're not going to report psoas muscle weakness. They're not going to report, George's line abnormalities. They're going to report a lot of disc issues, foraminal issues, because those are the procedures that are relative to back pain. The same thing applies anywhere else. They're looking at meniscus in the knee, looking at arthritis, because they don't know what else to look for except for the procedures that they already deem as acceptable for pain. They're taught to look for the things that we already treat. In the shoulder, they look at the rotator cuff and the labrum. They don't look at deltoid thickness or, other types of issues there. They're not looking at like the bursal thickness there. So you can see by every region, there's actually an inherent bias in the way that radiologists read MRI reports based on the types of procedures that we treat in those areas. So in the spine, it's discs. In the knee, it's particularly the meniscus. In the ankle, they're not really sure what to do, so they call it all arthritis. In the shoulder, they love the rotator cuff and the labrum. In the elbow, they're mostly looking at the UCL. And if it doesn't match up with one of those procedures, they kind of go, I don't know what to tell you. It's in your head. Then we refer you to a psychiatrist. Like, what kind of crap is that? So we can see there's some inherent biases when we talk about that kind of stuff. So when we truly have discal issues, we don't really care about the localized pain because that usually is self-limiting and goes away. What we care about is long-term neurological function. So if your nerve root is compressed for a long period of time, it can die and start to go away permanently. So you can lose that S1 or that L5 or L4 permanently if it doesn't get uncompressed. Same thing with neuropathies. If you have a neuropathy for long enough, those neurons can die permanently. Same thing with a polyneuropathy. So what are some examples of polyneuropathies? Diabetes mellitus, Guillain-Barré. What else? You could have a host of Hashimoto's. Fibromyalgia could be considered a polyneuropathy. What else? You could have oxygen symptoms from emphysema. People with congestive heart failures can show peripheral neuropathies as well because they don't distribute oxygen into the periphery. What are some demyelinating diseases? Polio, Guillain-Barré. Yeah. So MS would be a polyneuropathy, for sure. Okay, so okay, and now we're going to break these down into upper motor neuron and lower motor neuron presentations. So we're going to define an upper motor neuron as a neuron that is above the spine itself, outside the spine itself. A lower motor neuron is going to be outside the spine. So you can have an upper motor neuron presentation. Okay. So an upper motor neuron, give me an example of an upper motor neuron presentation. An ischemic stroke, a hemorrhagic stroke would be examples of that. Everybody ever heard of Brown-Séquard syndrome? So Brown-Séquard syndrome is an impaction just below the skull level into the spinal cord that will give a very stroke-like presentation, except that there'll be no cognitive deficits because all of it happened below stream. So it'll look exactly like a hemorrhagic stroke, except for the person has no problem speaking, no problem with memories, and no problems with other types of cognition. Okay. Different types of TBIs can certainly give us upper motor neuron presentations. Yeah, traumatic brain injuries. So upper motor neuron presentations, because they present above the thalamus where we decussate, they were going to give us across the body presentations. So if I have a right-sided issue over here, right, I'm going to have a left upper motor neuron presentation. So it could be in my cortex, it could be in my thalamus, it could be somewhere along up here. Brown-Séquard would also be there as well. Okay, so it'll cross the body to the other side. A lower motor neuron presentation is going to occur on the ipsilateral side. So that's going to be a neuropathy, right, a pure neuropathy. Lower motor neuron lesions are almost always neuropathies, but they could be polyneuropathies as well. So diabetes mellitus would be a lower motor neuron presentation, just multiple, right? So important to differentiate between those types of neuronal presentations. So is a disc herniation an upper motor with radiculopathy an upper motor neuron lesion or a lower motor neuron lesion?
So you said lower was outside the spine. So it would be upper.
Lower.
Lower.
It's a lower motor neuron lesion. It's ipsilateral. It's outside the spine. It doesn't decussate, right? It occurs in a level below where the neurons cross over to the other side. So an ischemic stroke in my right hemisphere is going to give me symptoms where? From the right side of the body to the left side of the body? Left, generally speaking. Exactly. So that's one way you can differentiate the two. So I would have a spasticity oftentimes in the contralateral portion of the body. Now, could I also have a lower motor neuron presentation that happens eventually as well? So think of my hand as like this for an extended period of time. Could I develop carpal tunnel too? Of course I could. So that's the thing. So people will ask me if I treat people with stroke. I say I treat the biomechanical components of it, and we don't necessarily know if we can help them until we actually treat them or not. People will assume that all their symptoms are a byproduct, right? So this kind of works on our feed forward and feedback mechanisms. Like people think of the conscious brain as something that exists outside of our normal physiology. It doesn't. It's based upon your own physiology, your neurochemistry, what's in your blood currently. Just like people get hangry when our blood sugar is low. So your personality actually alters because of your blood sugar. So if you think that you're distinct and different than your body, you are crazy. Our consciousness is a byproduct of our body, and our body is a byproduct of our consciousness. They work together in synchronicity. It's a feed forward and feedback. So you cannot take your consciousness and put it into a computer. It cannot happen. We are a byproduct of your neurochemistry. You don't believe me? Take LSD or DMT or mushrooms and watch what happens. If you think your reality is so concrete that neurochemistry isn't affected by chemicals in your body. DMT, dimethyltryptamine, don't take it. It's what they call the God molecule. It gives you a near-death experience, essentially. Stored in the pineal gland. Yeah, it can change your world dramatically. It's not for a novice psychedelic user. But there's always this feed forward and feedback. So in the same way, if I have a stroke, there's a feed forward and feedback. So I may lose my feed forward from the brain, but what can happen there is I start to develop these biomechanical consequences secondarily that might be able to be fixed, right? So then because I can't move my arm, everybody just assumes that it's coming from the brain, but sometimes they might also just have a shoulder issue there as well. And so if we just treat it, all of a sudden they can move that arm, then we have the feedback back to the brain, so the neurons are firing and making this part of the brain healthier. So it's the same way that people use like mirror boxes to treat phantom limbs and things like that. Like they have in their brain, they perceive it as a fixed or frozen limb. So they'll use a mirror box, they put a mirror there, and they tell them to move both hands together. And because the brain can see that hand moving, it breaks it free and it takes the perception away of the pain. Because pain is a completely and utterly subjective experience. Okay, so it's a feedback and feed forward. It goes both directions. So just because I have a stroke here doesn't mean that it's not causing a biomechanical issue that can be helped greatly. Then once it's helped greatly, then it helps the brain out. Okay, but sometimes it's also just purely neurological, but you don't know until you actually treat them. And like I was telling somebody today, it's like you owe it to your patient to at least try. I mean, I've had so many cases that I would have sworn they needed surgery, but then I just gave it one try and I was able to fix them. Even though all the presentations matched up to everything that I would consider as a surgical candidate in certain cases. Again, it's a numbers game, right? Anybody who knows statistics knows that nothing happens at absolute values. There's outliers across the board. Some people genetically respond different to different types of therapies. Okay, we don't just get rid of them because they don't fit our narrative. What matters is the individual experience. And if you don't give them a chance in the individual experience, then they fall victim of the system. So you always have to do your due diligence and try. Now, if it doesn't work after 2 or 3 sessions, again, you can't be a swindler, right? You don't want to be that person, so you want to refer them to the right place. But also give it a shot. Unless you think you may harm them, right? Do no harm. There's a chance that you might be able to help them. But you also have to know your limitations. For me in particular, if I don't see at least like a 30% change on somebody, I know they're going to backtrack, particularly if it's a chronic issue, back to 10, and I won't be able to overcome that with a multitude of treatments. So if I can get a 50% jump on visit 1, that means that in my mind's eye, I think they'll slide back to 30, and then if I treat them again, they'll get to 75, and they'll slide back to 50. So eventually we'll get them over the plateau. If If I only get 10% change, odds are they're going to come back in exactly where they started on my first visit. Okay, and we're just spinning the wheels and I'm wasting their money and time, and they could be getting the right therapy somewhere else. Does that make sense? Okay. All right, so if I have weakness in my wrist extensors, what myotome is that? C6. Weakness in my triceps, what myotome? Okay, weakness in my triceps, what nerve? Radial. Good. Okay, weakness in wrist flexion, what nerves? Good, ulnar and median. Okay. Weakness in thumb extension, what nerve? Radial nerve. Weakness in thumb extension, what myotome? C8. Okay, you're confusing the dermatome and myotome again, right? Okay, weakness in deltoid activation, what nerve? Axillary nerve. Weakness in deltoid, what myotome? C5. Okay, weakness in bicep flexion, what myotome? You said it earlier. C5, 6. Okay, weakness in bicep or elbow flexion, bicep activation, what nerve? Musculocutaneous. Weakness in wrist extension, what nerve? Radial nerve. Weakness in wrist extension, what myotome? C6. Good. Exactly, 6. C6. Okay. Numbness in the middle finger, what dermatome? C7. Numbness in the thumb, what dermatome? Good. Numbness in the pinky finger, what dermatome? Numbness in this part of the forearm, what dermatome? T1.
Oh, that's right.
Numbness here, what dermatome? T2. Numbness here, what dermatome? Okay. What's this? What's this? What's this? What's this? Good. Great toe extension, what myotome?
C5. No, well, myotome.
Myotome, L5.
What would I say?
C5.
I
I don't even know. All right, weakness in knee extension, what myotome? Okay, weakness in plantar flexion, what myotome? Okay, weakness in knee extension, what nerve? We haven't done it yet. What is it? Femoral nerve. Femoral nerve innervates what muscle group?
would say
The quads.
quadriceps. I don't even know. I'm just saying words. I'm like.
Come on, you got this, guys. All right, numbness in the great toe, what dermatome? L4. Numbness in the great toe, what nerve? It can be deep peroneal or superficial peroneal. Okay. Numbness in the heel, only the heel. What nerve? The posterior tibial calcaneal, posterior tibial primarily. Okay. Numbness in the heel, what dermatome? S2, S1. S2 is arguable. I'll give him credit on that one. Okay. Numbness of the lateral foot, what dermatome? On the bottom. S1, good. Okay. Weakness in... Like, where am I going to get him now? Where am I going to get him now?
Oh, yeah.
All right. All right, history of head trauma. Inability to extend the elbow. Am I looking at a lower motor neuron lesion or an upper motor neuron lesion? Upper, good. Okay. History of stab wound to the neck. What disease state? And is it an upper motor neuron or a lower motor neuron? Brown-Séquard syndrome, and it's an upper motor neuron lesion. Okay. Diabetes mellitus, is it lower motor neuron or upper motor neuron? Lower, very good. So if I suspect somebody has an S1 and they have numbness in both feet, what question might I want to ask them? Right. Do you have a history of diabetes? What's your A1C? Right. So this patient had seen this other provider 4 or 5 times, but that conversation never came up. Again, you talk about asking the right questions. So when I started to get a positive on the other side, but they didn't have symptoms, I was going, wait a second, you don't feel that either? No. So neither of those feel sharp to you. No, they don't feel sharp. So he felt it, so if I didn't clarify that it didn't feel sharp with my pinwheel, I would have said, oh, he feels them on both sides, they feel the same. Because, generally you're looking for symmetry from side to side. But in this case, they were symmetrical, he just couldn't feel sharp. Why? Because he has diabetes. So how could you find out if it's L5, L4, or S1, or S2 in the foot if the whole foot doesn't have any sensation like that? You can't. So this patient presented with pain here, but it stopped, on the way down, didn't go all the way to the foot. So they assumed it was piriformis syndrome because they had pain in the butt and it kind of shot down, but didn't go all the way to the foot. It didn't look like the S1 because that part was numb. So they assumed it was piriformis, but guess what? They treated piriformis and it didn't get better. So what does that do? That rules out piriformis, right? Okay. So knowing that, then we think, what? L5. Okay. Where does an L5 radiculopathy show up? Between what 2 vertebrae? L4 and L5. Okay. Good. Where does S2 show up? In the sacral foramen, right? What congenital condition could cause me to show an S2 radiculopathy? What's an example? Okay. Primarily lumberization, but also spina bifida is possible as well. Transitional vertebrae, which can happen at any kind of transitional area, but it's most prominent at L5 and S1. They take on the characteristics of the other one to the point where they actually are fused or have an extra movement there. So, and you'll see that on MRI reports and stuff too. Like you'll see them say, for the purposes of this, we're going to call L6 blah, 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 or S1, whatever they want to name it, which is arbitrary based on what the radiologist wants to call it. Okay, so if I have numbness in my middle finger, what kind of dermatome am I talking about? C7. Okay, numbness here, what am I talking about? Okay, weakness here. Okay, weakness here. Okay, numbness in my pinky finger. Okay, numbness in my pinky finger. What nerve? Ulnar. Possible entrapment sites. Good. Yeah, good. Numbness in my thumb, index, middle finger, but it spares this part right here. So it spares this. What nerve?
Oh, nerve.
Median. Okay, what structures might compress it? Carpal tunnel. So what structure in the carpal tunnel primarily? The transverse carpal ligament. Peroneal teres primarily. Good. Okay. So if I have entrapment at the lateral elbow near the supinator, what nerve might I have that would cause elbow pain that's an entrapment there? It's a branch of the radial nerve. Nope. We talked about this previously when discussing elbows. Nope, it doesn't. The posterior interosseous nerve, the pin, can mimic tennis elbow, right? Remember that? You gotta remember everything I ever tell you guys. No big deal. Okay, weakness in the great toe. What myotome? 5. Weakness in thumb extension. What myotome? 8. Weakness, not numbness. Numbness in the thumb. What dermatome? 6. Okay, weakness in Bicep activation. What nerve?
No,
Musculocutaneous. Okay, I tilt my head to the left. It increases the symptoms shooting down my right arm. Plexopathy, neuropathy, radiculopathy. Plexopathy. I tilt my head to the right. It increases the symptoms going down the right arm. Plexopathy, neuropathy, radiculopathy. Radiculopathy. Good. Okay. What is the position of maximal foraminal encroachment? The position of maximal foraminal encroachment in the C-spine. Extension, rotation to the same side, and lateral flexion. That narrows the foramen to its most small place, right? So that would be another test that you would expect to increase the symptomatology. So if they looked up and tilted their head that side and it shot down their arm, again, that would tell us the likelihood of radiculopathy is higher. So think about the holes there in the cervical spine, right? So if I bend towards, I narrow them down. If I extend, I narrow them down. If I rotate, I narrow them down. The combination of those three motions, lateral flexion, okay, extension, and rotation ipsilaterally, give us the smallest amount of possible foraminal space. And if you added compression to that, that would decrease it even more, correct? What is that test also used for? Okay, it's to see if we have vertebral artery impingement, to decide if somebody might or might not be a candidate for manipulation. What symptoms might we see if somebody was not a candidate for manipulation when we put them in that position? Dizziness, nystagmus, possibly slurred speech, because why? We've created what? Ischemia. Temporary ischemia, because we've cut off the vertebral artery. So that vertebral artery goes primarily where? Okay. What branch comes off of it that could be the most significant? Okay. The posterior inferior cerebellar artery, or the pica. And when it sneezes, we call it Pikachu. Boo. Somebody boo this man. Nystagmus, so it's beating of the eyes. Isn't familiar with the term nystagmus? So if I was checking, and you should check this in your exam class, but one of the ways we check for benign paroxysmal positional vertigo is by checking for nystagmus. So one of the mistakes people will make when they're checking the position here, so you're going to hold your head straight and you move your finger from side to side. You should move it in an arc, because when you move side to side right here, what's going to happen is the nose is going to block the input from one eye. So when my finger's here, okay, I can't see it with this eye. So you're going to get nystagmus here as you follow, because this eye can't see it anymore, so it's going to beat looking for it. Your eyes are designed to move together and synchronously. So I'll show you guys in a second. So you need to make sure you loop it far enough around, okay? But oftentimes, because we have our blind spots as well, right, we can run into issues where it disappears here. So if you find your blind spot, mine's right about there. And I'll show you guys a little trick with the X. Did we do that with the X in the circle? Let's show you guys that too. Okay.